come up. So first of all, welcome to Brighton and Sussex Monthly Lecture. Hopefully you are in the right place this evening and are expecting a talk on HIV today. So we are recording this talk and we will be putting it up onto our YouTube channel once we've edited it and captioned it. I should introduce myself. My name's Claire. I work in the admissions and outreach team at Brighton and Sussex Medical School. So I help facilitate these types of talks, go into lots of schools and those sorts of things as well. I'm going to be more in the background today. I will be answering any kind of questions you might have around admissions in Brighton and Sussex Medical School. Hopefully on your screen you can see a little button that says Q&A. If you have any questions today with regards to the talk, if you can put them into the Q&A and Fionnuala will then answer them at the end of the talk, and we'll go through them and we'll try and get through as many of them as possible. So we will try and answer the question, like I said, as many questions as possible, but time may be restricted. We will finish very promptly at 7:30 because we're aware that people have evenings and things to go and do afterwards. So I will just introduce Fionnuala. So if I can find it, here we go. So Dr. Fionnuala Finnerty is a specialist registrar in HIV and sexual health and a clinical teaching fellow at Brighton and Sussex Medical School. She has a special interest in the barriers to effective HIV care. She previously completed an HIV exchange fellowship and worked in Harare, Zimbabwe in 2016. So I will hand over to you, Fionnuala.
Thank you, and welcome everyone. My name is Dr. Fionnuala Finnerty, and my talk is entitled The Big Disease with the Little Name. Now, I wish I'd come up with that title myself, but I actually stole it from a Radio 4 podcast, which tells a little bit about the history of HIV, and I'd really recommend it if anyone is interested after hearing this talk about finding out a bit more about it. So the reason that I went into HIV and sexual health, that's my specialty, is I'm quite interested in politics. I'm quite interested in social justice. And it seemed to be a specialty where there was a big intersection between medicine, politics, new therapeutics, and there was also a strong history of activism. And I'm going to talk a little bit about how when the epidemic really began to take hold a few decades ago, that actually activism and patient activists and collaboration between healthcare workers, patients and the community really, really helps to benefit and push forward treatment, therapeutics and care for patients. And actually, we've recently had a pandemic, and a lot of the lessons that were learned from the HIV epidemic informed the coronavirus pandemic. And if I have time, I'll touch on that a little bit. So the next thing I'm going to do is I'm going to use Mentimeter just to find out a little bit about you, where you're from, and what your ideas are about HIV. So bear with me while I do my slide jiggery pokery. And where is my Mentimeter? Oh, here we go. So I'm just going to share this, and hopefully you'll be able to see it and answer where you're from. Okay, Brighton, not far. Coventry. I used to work in Leicester, which isn't far. Cardiff, Chesterfield, Newcastle. I'm from Ireland, in case you hadn't noticed or guessed. Okay, wow, this is cool. Okay, so we've got people from all around the country. Just wait a few more minutes. Most people are from London. Oh, South Korea, wow. Great. Okay. Japan, Cyprus. Okay. Oh. Okay, great. If anyone didn't have an opportunity to say where they're from, don't worry, I've got kind of a flavor. Okay, so the next question. So I'm just wondering how old you all are. And I'm not just asking to be curious, it will make sense in a minute. If you could answer, okay? Great. 55, 35, 16, 14. Great, okay. Majority people are around 17. Okay, right, and we're going to go to the next question. What one word would you associate with HIV? Lifelong, virus, deadly, stigma. Oh, that's a good one. Prejudice, untreatable. Hopefully we'll prove that that's not the case anymore. Retrovirus, lowered immune system. Okay, very interesting. Lots of really interesting words here. Yeah, so stigma's coming up. AIDS. Okay, politics, transplants. So lots about prejudice. Death. Okay, well, hopefully we're going to talk about that now, because that was once the case, but is no longer the case. Okay, great. Okay, brilliant. So that's very, very interesting words here, and we're going to talk about some of these things in the course of the talk. So I'm going to move now back to my slides, and then we're just going to briefly, I mean, it's quite a huge topic I selected, but we're going to move briefly through the history over the last few decades, and then hopefully we'll have time for a few questions at the end. Here we go. Okay, great. Now, the reason I asked you how old you are is because despite my very intensive skincare regimen, I am actually 40 years old, which I'm sure you can't believe. So the reason I say this is because the HIV epidemic really took off 40 years ago. So my whole lifetime, the HIV epidemic has been evolving. And as I've grown up, it has as well. So this is the first case report. So basically, this is the first thing that was published, kind of talking about what we now know as HIV, but at the time they didn't know. It wasn't a name. They didn't know what the disease process was. So basically, on the 5th of June, 1981, just before I was born, MMWR, which is Morbidity and Mortality Weekly Report, which is a bulletin that is put out by the Center for Disease Control in Atlanta, Georgia. So in their bulletin, they had 5 cases, which came from Los Angeles, which said that there were 5 men who had sex with men, so 5 gay men, who had died or become really unwell with a fungal pneumonia called pneumocystis carinii. So pneumocystis carinii is quite a strange pneumonia. It's also known as PCP. And it doesn't happen in people whose immune system is functioning well. It happens in people who are what we call immunocompromised, which means that their immune defenses don't work very well. And it was a bit strange because they were young, they were fit, and all of a sudden they got this pneumonia and they became extremely unwell. Now, these case reports started to pop up around the place. There was one from Los Angeles, one from San Francisco, some more from New York. It started in metropolitan centres in America first, but then the cases started to pop up in London and in other metropolitan cities around Europe. At the same time, there was a disease that was showing up in Africa. It was where young, previously healthy people began to get these illnesses that would normally be associated with people whose immune system was not working well. And this was called slim disease. But because the groups of people were quite different and disparate, they didn't link the two diseases together, at least not at the beginning. So, Claire, could I just have 1 second just to have a look at my slides? Is that okay? I'm just going to turn my camera off for a second. I don't know, I have had some kind of gremlins in my, and I might just need to pop it back, otherwise I'm going to lose my train of thought. I'm so sorry, everyone. Just give me 1 second.
No, that's fine. I'll answer some of the questions that come in actually. So I'm currently answering about work experience. So there is a question here about work experience. So basically what I've been writing is medical schools are very aware that work experience is quite difficult for students to access at the moment. It's getting easier now that we're coming out of the COVID restrictions. However, we are very aware of that. The Medical Schools Council have put a statement out with regards to gaining work experience during COVID, but also you don't necessarily need to have clinical work experience. You can get a lot of experience working in a cafe, a fast food restaurant, whatever it is, because in those situations you are developing your team skills, your communication skills, organizational skills, time management. So you can get a lot from those sorts of things. So someone's asked about international students studying biomedical sciences in the UK. So at Brighton and Sussex Medical School, we don't have a graduate programme, so we don't run a 4-year programme, we just have our standard 5-year programme. We do have a lot of graduates that will come on to that. Caitlin, with regards to further reading, and what types of books would you recommend? So I wouldn't say you need to do loads of extra reading. Okay, obviously having a good sense of the NHS and what is going on, being up to date with more current affairs within the NHS and the health service. So obviously there's loads of things in the news about waiting lists, because obviously they've gone through the roof since COVID. So being aware of like current affair topics is really important. So that's a really good one. When you get to medical school, you'll be doing a lot of reading anyway, so you don't need to like drown in it before you come to medical school. So you don't need to do any extra study before you come, because we wouldn't expect you to know certain stuff, and we will be teaching everyone the basics when they arrive to make sure everyone's at the same level. So so don't worry too much. We will put a reading list, so things like This Is Going to Hurt, the Adam Kay book, lots of people read that, and obviously that's just been made into a BBC programme as well, which people are kind of watching. So you might have seen that. I'll hand back over.
Hi, I'm so sorry, everyone. I spent the day doing this talk, and the most up-to-date version has been, the file is corrupted. So lots of my lovely pictures are not available, but I will put some links in the chat about where you can look them up and how you can do that. But there's still lots that we can talk about, and it's just a bit of a pity about the pictures. So here we're talking about this report that came out from the CDC about 40 years ago. So what happened from there is basically small groups of doctors started to say, this is a bit funny that these patients are having these opportunistic infections. So the infections were like this pneumonia we described. There was also something called Caposi Sarcoma, and Caposi Sarcoma is a skin disease. It's caused by a human herpes virus type 8, which is just a virus. It doesn't normally cause many problems, and most people have been exposed to it at some point. But if your immune system doesn't work very well, you can get this quite disfiguring skin disease, skin illness. And you can get these kind of violet, purpley sort of nodules. And I don't know if anyone's seen the film Philadelphia. I mean, most of you seem to be quite young. It was Tom Hanks years and years ago, but it was a film about somebody who essentially had constructive dismissal from their work because they were living with HIV. So as I said, in the beginning, they weren't really sure what was causing these young people to mysteriously get ill. And what happened then was basically people had a series of different infections. So the way HIV works is you've got these immune cells in your body. They're called CD4 cells. And they're like helper T cells. They help your immune system to fight infection. The virus comes along, it attaches itself to the cell, and it gives it what we like to call like a toxic hug. So what happens is all the material from the virus ends up inside the cell. It takes over, it goes into the nucleus and takes over the cell's control center, essentially. And then it just starts like a narcissist. It starts just reproducing copies of itself. By using the cell's machinery, it actually kills the cell and then lets out loads of virus into the bloodstream. As the CD4 cells become damaged and die, then people are susceptible to these immune infections. Now, part of the problem in the beginning was it affected certain groups of people. So it affected men who have sex with men. It affected hemophiliacs. So that was one of the things that suggested that there was a blood-borne route, that you could get it from a blood transfusion, because hemophiliacs require blood transfusions. It also affected heroin addicts, so people who injected drugs. So that suggested a blood-borne transmission route as well, because when people share needles, they can share blood between people. So at that time, some of those people were quite stigmatized communities or marginalized communities. It also affected people. Initially, one of the things is that people used to joke that it only affected groups of people that began with the letter H, because the other group of people that it seemed to affect were people from Haiti. Now, it turned out that people from Haiti were no more likely to be living with HIV than other people, but they were also a group of people. So what happened then was there wasn't a huge amount of money being given towards the diagnostics and treatment of the disease. So people didn't really know what it was. People were scared. It affected certain communities. The politicians were worried about talking about a disease that had something to do with sexual contact. And there was a very slow start and a slow response to HIV prevention and treatment. So it took a few years for the organism itself, for the virus to be identified. Basically, they identified the virus in two different centers. So in one center in France and in one center in America. And so they knew then that they had identified the correct virus. So initially, they called the disease gay-related immunodeficiency because they thought that it affected mostly gay men in the beginning. But then they were able to identify it as a retrovirus, which some people put on the slides. And they were able to start thinking about how they might treat the disease. So this was a disease that affected mostly young people and that led people to die within 2 to 12 years. And most people who acquired HIV in the beginning, they died. So the majority of people died, and they died with quite nasty illnesses. So it was a very horrible thing, especially for certain communities where large numbers of people's friends and families may have died from this illness. And it was quite stigmatizing at the time. So in certain hospitals, they wouldn't treat people who were living with HIV or AIDS in the hospital. In some other hospitals, they had guards outside the door so that people couldn't leave. And I don't know if anyone's seen It's a Sin. So It's a Sin is a television program that was on Channel 4, and it talks about mostly the gay community affected with HIV in the 1980s in London. Basically, what happened after that is that people began to get very angry. And unfortunately, I have no pictures. I had loads of pictures of the activists and the protests. So I'm sorry about that. But there's lots of stuff you can look up. If you look up on Nature, the magazine, I'll put some stuff maybe in the chat, where you can see pictures of activists. So there was activists in America, there was activists in England, there was activists in South Africa. and they've made different groups. So the activists in London and America were called ACT UP. The activists in Africa were called the Treatment Action Group. And so what they said is, we need treatment. First of all, we need treatment, we need drugs. So the National Institute of Health in America was run by a man called Anthony Fauci. You may know about him if you had been following Trump and his advisors around coronavirus. So he's 81, he's still working, and he was the head of the National Institute for Health. And basically, in the past, the FDA and people so the Federal Drugs Administration, or organizations who register drugs and who test drugs to make sure they're robust and they don't cause problems, had run into trouble with thalidomide. So thalidomide was a drug that was given to women who were pregnant for morning sickness, but it caused quite significant abnormalities to the baby. So after that, they were very, very careful about licensing and making sure that all the drugs were tested robustly. So this is a picture here of AZT, or zidovudine, which is the first HIV treatment that was ever commercially available. And that happened in 1987, so 6 years after the epidemic had taken off. Now, the epidemic took off in 1981, but actually HIV originated quite a number of decades before that. It passed from primates in Africa through to humans, but it took quite a number of decades before the epidemic really took off in earnest. So HIV is not 40 years old, but the epidemic is 40 years old. So this is AZT. It's the first treatment that was available, and it was deemed as a real success that finally we had something. The problem is that HIV is a virus that likes to replicate itself very, very quickly. So it's very clever. It makes loads of copies of itself. The problem is, when it's repeating and copying itself, it makes errors. So in order to treat it properly, you need to treat it with at least 2 different or 3 different agents. And that's to stop it from becoming resistant. So AZT on its own was not a good enough treatment. And actually, it worked temporarily, but then the HIV got very clever, and the AZT wasn't enough to keep it under control anymore. So even though it was an effective medication, in isolation, it wasn't good enough. So this is a picture of the AIDS Memorial Quilt. So this is a quilt that was made by activists and family members and community members and people in America. And every panel of the quilt was made for somebody who died. Up until 2020, 37.3 million people are thought to have died of HIV and AIDS since 1981. That's more people than died during World War I. So it was a very, very, very lethal disease at the time. And it took a very long time for effective treatment to be established. This quilt was laid in America. It was brought over to England. There were similar things done in Africa. And it was basically kind of a creative way for people to represent and show, what had happened to their loved ones. And it's very visceral. The panels are really amazing. And it's got an online exhibition, so you can have a look at it if you ever felt the need to do that. So this is ACT UP. These were one of the activism groups and the campaigning groups. And they were very vocal. And so they made T-shirts, they made signs, and the signs had things like "Silence equals death," "Fight AIDS, ACT UP." And they really had a great campaign where they talked to politicians, they talked to leaders, and part of the reason that they managed to start with the HIV Drugs Campaign is that the people from ACT UP did a protest outside the National Institute of Health, and they were asked to go in and speak to Dr. Anthony Fauci, who was the man who was responsible from the National Institute of Health for making new medications and making decisions. And he spoke to them. They were very informed, and they were very passionate. And he actually went to their meetings and he collaborated with them in order to think about how HIV drugs could be made and how HIV treatment could be evolved. So what happened then was, basically, we're in a situation, we've got a deadly disease, difficult to get politicians to engage, a slow start, but some activists got involved, and then slowly, as the epidemic took off, more and more people became vocal, more and more people got sick. It became more necessary to really take it seriously. So more money was put into the production of new medications, and a really good thing happened in 1996. So as I discussed, HIV likes to replicate, it can mutate, and there can be drug resistance. So we needed more than one medication. So in Vancouver in 1996, they presented the first signs that actually there was going to be effective treatment available. And this was triple therapy, and it basically included a new type of medication called a protease inhibitor. Now, I had a lovely slide that I wanted to show you before my files all got corrupted, but essentially, it was a huge burden of medication in order to effectively treat HIV. So you needed multiple tablets. So sometimes people were taking 15, 16, 20, 25 tablets a day. But at least it was the first medication that worked. It was the first sign that actually we may get effective treatment. The medications themselves cause a lot of side effects. Some of them had to be drunk with pints and pints and litres of water. Some of them caused kidney stones. Some of them caused anemia. Some of them caused vomiting. Some of them caused horrible diarrhea. However, they were still treatment. Come 2006, we had one pill, a single tablet regimen. And now we have loads and loads of single tablet regimens. And it's really, really amazing. But there is still a lot of stigma, as a lot of people put in the chat. So I'm going to talk about a bit about stigma, and then I'm going to talk about where we're at now and what has changed and what has moved on now. So somebody put in the chat untreatable and uncurable, and I'd just like to say a couple of things now. Is that was the case many decades ago. But if you were diagnosed with HIV now, you will likely have a normal life expectancy. And I think that is amazing that in 40 years, it has gone from a serious, almost universally fatal disease that led to horrible illnesses and affected young people in their prime, to a disease that is eminently treatable. Not only that, there was lots of barriers to people living with HIV. So between 1987 and 2010, if you were living with HIV, you weren't able to go into the States. It wasn't always enforced, but it was illegal for you to fly to America and go into America and stay. Until 2020, you were unable to be a pilot in Europe if you were living with HIV, and that's gone now as well. If you are on effective treatment, and effective treatment means you have an undetectable viral load. So viral load is the amount of virus in your blood, and we check it and test it when we have patients who are living with HIV. If that's undetectable, which means we can't find it, or that you've got less than 40 copies of the virus in 1 ml of blood, then it is impossible for you to transmit the virus to somebody else sexually. So, I mean, that is amazing. So that has really reduced the amount of people that are being diagnosed, because people who are on effective treatment cannot pass on the virus to someone else. The other thing that has become available is PrEP, pre-exposure prophylaxis to HIV. And that is a tablet that people take every day or 4 days a week, that stops them from acquiring HIV. So these are all really important preventative measures. But there still exists some stigma. So here are a couple of recent sort of things. So in 2015, Nigel Farage made some very serious comments about HIV. So he is from UKIP, and so they have an anti-immigration stance. And he said in a political national TV interview that people living with HIV were coming to the UK as health tourists. So what they wanted to do was get funded HIV treatment. That was massively debunked. It's not true. And that was debunked by the British HIV Association and the National AIDS Trust. But the problem was that went viral on social media, and the message was everywhere, even though the message wasn't correct. Another thing that is just an example is that Avon and Somerset police said that they were at risk of HIV, and that they were going to insist on wearing spit hoods. So HIV can't be transmitted by spit. It's not. It is not transmitted by spit. So that was another thing, and then they were forced to apologise. But there's lots of examples. If you put in HIV stigma, that people are concerned about stigmatizing language. People are afraid to tell their dentist that they're living with HIV, and there still exists a lot of work to be done around stigma. So we talked about U, we talked about PrEP. This is another very interesting thing that has happened recently. So at the moment, you can be undetectable, so you can have no evidence of HIV virus in the blood if you take treatment. That will mean you may have a normal life expectancy. That you will likely have a normal life expectancy, and that will mean that you won't get these diseases that are associated with your immune system being low. So that's really good. But you will need to take lifelong treatment. So essentially what I'm trying to say is we have no cure, and we have no vaccine. We have got no cure. But some people, a very small number of people in the world, have actually been cured of HIV. And it's a little bit of a complicated concept. So I'm going to talk I'm going to give you the basics. So basically, people living with HIV are more at risk of getting disease, cancers of the bone marrow. So things like leukemia and lymphoma and diseases like that. Now, if somebody has a very serious disease, they may need a stem cell transplant. So what happens then is that you would have irradiation. So you would get irradiation, so you receive irradiation treatment, and the point of that would be to damage your bone marrow, and so that your stem cells would be damaged. And what would happen then is that you'd get repopulated with cells from another person. Now, one of the receptors on the CD4 molecule for HIV, some people have a mutation, which means it's a different shape. And so when people who were living with HIV needed the stem cell transplant for another reason, because they had this cancer, what they did was they transplanted them from somebody who had this receptor that meant that HIV couldn't enter the CD4 cell. And so there were 3 patients. So there was Timothy Brown, he's the guy on the bottom left, he lives in Berlin. He had a stem cell transplant more than a decade ago. He's not been on HIV treatment since then, and he has an undetectable viral load, so there's no evidence of HIV. The top article is a very scientific article, but it describes a patient in London where a similar thing happened. And then in the last 6 months, there's been a description of the same thing happened with another patient, a female patient. Now, this obviously is only something that would happen if you needed a stem cell transplant for another reason. A stem cell transplant is extremely dangerous and very toxic. So it is not a treatment in itself. But I just think it is very interesting that, you know, we always said that it was essentially incurable. It's very treatable, but it wasn't curable. But some of these patients have been cured. Okay. So I also just wanted to talk about the number of people living with HIV at the moment. So at the moment, the place where the epidemic is really centered around East and Southern Africa. So actually in Europe, there are not that many people living with HIV compared to the general population. So a lot of efforts need to be made to ensure that people living in East and Southern Africa get access to effective treatment. And that has really been pushed by the UN. So they had 90-90-90 targets. So by 2020, 90% of people worldwide who were living with HIV were supposed to know their diagnosis. So they were supposed to have been tested. 90% of those were supposed to be on treatment, and 90% of those were supposed to be undetectable. Now, that was met in England and in some other countries, but it wasn't met in certain countries. So lots of resources and things need to be used to make sure that there is access to treatment and that it is equitable in different countries. So what happened in I'm going to use South Africa as an example, is that they had the epidemic started slightly after the epidemic started in the metropolitan cities, as I discussed before. But it became very, very prevalent. So lots of people became infected. And there was a bit of a problem because one of the presidents of South Africa, his name was Thabo Mbeki, at the time when the HIV epidemic was really taking off, he said in a statement that HIV didn't exist, and that it was just all, you know, like he didn't believe in it, and he was the head of state, and so he didn't want to invest in it. And they a report by Harvard University suggested 300,000 people may have died as a result of this. There were lots of activists and people really involved, and things like the Treatment Action Group. So what happened was they began to realize that treatments were available, but they were unable to access them in their country. And so they really, really lobbied hard for the medications to be available in their country. And they wanted them to be supplied as generic. So basically, when a drug is made by a drug company, initially it may be a branded drug, so it may be a bit more expensive. And then when the patent for the drug, so that means that the drug company is the sole supplier of that drug, runs out, then it can be produced generically. So it's not branded and it's much, much cheaper. So there was a big push from activists and people in this group to try and get the medications as generic, so that people could be treated. And so then this is quite interesting and recent from what used to be Public Health England, is that lately, in the latest statistics, heterosexual HIV diagnoses have overtaken those in gay men for the first time in a decade. So I think what that means is that our preventative strategies are working, but we may need to consider who we're giving PrEP to. So PrEP is the pre-exposure prophylaxis, so the preventative medication, how we're diagnosing people, who we're putting on treatment. But we've seen a massive fall in new diagnoses, and hopefully that will continue. So there was a cover of The Economist about 10 years ago, which said maybe the end of HIV and AIDS is in sight. Some more of the new exciting things that were that are available is there's been some injectable medications. So there's some medications that can be injected as treatment, and the treatment lasts for 1 to 2 months, 1 or 2 months, depending on the strength of the medication. And this is a really, amazing advance, that people may not need to take tablets every day, and that they could have this injectable medication. Now, I might take some questions. I'm very sorry. I'm very sorry about the slides. I spent a number of hours today putting some beautiful photos together. But what I can do in the chat is give you some information that if you're interested and you want to learn a bit more about the history, the diagnosis, how treatments evolved and everything, so you can have a look yourself. But I'm very happy to take questions in the Q&A.
There is a couple of questions. So there's one, the first one, what is an opportunist infection?
Yes, so an opportunistic infection is an infection that happens when your immune system isn't working properly. So if you were immunocompetent, so if you're healthy with a normal immune system, you could be in contact with that infection and it'd be like, no problem at all. And, you know, it wouldn't even bother you at all. So an example is that pneumonia I was talking about earlier, pneumocystis carinii. There's also something called toxoplasmosis. It's something that you can get from cats. People who have cats have been exposed to toxoplasma. I've got a cat, I'm sure I've had it. I've been exposed to it, and people get exposed to it when they're young. They normally don't even know. It doesn't cause any problems really. But if your immune system doesn't work well, it can be very serious. And I think that's the thing about HIV, is that, you know, it just kind of brought out these kind of weird infections that were multi-system. So you could get a gut infection, an eye infection, a brain infection, lots of different infections. I saw another question that said, how does HIV become AIDS? Now that's a very interesting question that I would like to answer. So AIDS is acquired immunodeficiency syndrome. And basically the classic definition of that is if your CD4 count gets lower than 200, so a normal CD4 count, so a normal level of this white cell that functions for your immune system is probably around 600, over 600 or over 500, up to 1,000. And if your CD4 count was less than 200, that would be diagnosed as AIDS. But we actually don't use the words AIDS anymore that much, because we normally use the words advanced HIV, because now we have a situation that is reversible. When we didn't have any treatment, it was not reversible. HIV would develop onto AIDS. When you had a low CD4 count, you were very susceptible to these horrible infections. You needed to be on preventative medication to stop you from getting these infections, but eventually you would get sicker and sicker. And it was a very useful term back then, because we knew when people slipped into this phase that their immune system was very compromised and they were likely to get very sick. And it was a very dangerous situation to be in. Nowadays, you can get diagnosed with HIV, have a low immune system, so CD4 count low, start taking your treatment, and your CD4 count can come back up again. We normally would class it as advanced HIV. Some people still use the term AIDS, but basically AIDS is what happens when you get immunodeficiency as a result of HIV. So you have the HIV, which damages the immune cells, makes your immune system not function properly, and you get these infections. What can we learn from the HIV epidemic? So I think lots of things were learned. Lots and lots of things were learned, and lots of things were learned that were utilized in the coronavirus pandemic. So things like, you know, trying to get medication, using what you had to try and get medications licensed quickly when they were really badly needed. So stopping that very slow bureaucratic process. Another thing that really was learned is that you need to be in partnership. People with lived experiences have very powerful things to say and can really help you improve your service. So I think before, what we would say is, oh, you know, I'm the specialist and this is my service and this is what I think people need and this is what I think people want, and that's what we're going to do. Whereas now there's a much more collaborative approach. So it's like, what do you think of our service? What would you do? What recommendations do you have? Often services are designed with people who have lived experience, and I think that's really important as well. Is to I think it was a very difficult time for communication. People were very scared, and there was lots of difficult conversations to be had. So I think HIV clinicians that I've worked with are really good at having difficult conversations and chatting to patients. So I think lots of things were definitely learned. Stigma is still an issue. I think gradually it is improving, but there's still a lot of work to do. Yeah, I think there's still a lot of work to do. So I decided to specialize in HIV because I've got an interest really. I'm interested in global affairs. I'm interested in politics and just the whole story behind like how it happened. It's so fascinating. The clinicians that I work with and the patients have all taught me so many valuable things. It's like quite a young specialty, it's quite dynamic. They had to be very responsive, and there's a history of like continually learning on the job. HIV in the UK, HIV and genital urinary medicine go together. So you do HIV and you do sexual health. So you also do sexual health clinics, which are really interesting. And I'm very nosy, so I also really like that. And you get to talk to people about, like, you know, ask them lots of questions, get to talk to them about, all, lots of facets of their life. So you get to learn a lot about people. And it's also quite complicated science. I did like science. So the virology and therapeutics are quite complex. So, I mean, there's a bit of everything in it, something for everybody. I think it's a great specialty. Although we are doing so well with prevention, we may have to join up with acute med and do a bit of acute medicine in order just to make sure there's enough, there's enough work in the future. Brilliant question. If a parent has HIV, would their child definitely inherit it or not? So basically, if a mother is living with HIV and she is on effective treatment, so she is taking the medication and has an undetectable viral load, she will have a baby that is it is very, 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 very unlikely that she will transmit the virus to the baby. So mother to child transmission or vertical transmission of HIV is preventable. And so we really, really look after women when they're pregnant and look at their medication. And if necessary, we give the baby treatment for a couple of weeks after birth as like a preventative thing. But no, if a woman is on effective treatment, there's no risk to the child. What does it mean to have a test that results in a HIV diagnosis? There is, I can maybe put something in the chat, but basically there's a HIV, it's a 4th generation test, which looks to see if there's any evidence of HIV antibody or antigen, and it's quite a sensitive test now, so we can diagnose still quite early infections on the test. Oh, a lot of questions, some of them very complex to answer. One I really want to answer though, what does undetectable is untransmissible, otherwise known as U equals U mean? So what that means, and I think I've shown a slide about it earlier, but I'm going to repeat it again because if you can only remember one thing from this presentation, this is the thing. So if somebody who is taking treatment has an undetectable viral load, so you cannot, so when we test it in the lab, the viral load is undetectable, which means less than 40 copies in 1 ml of blood. And that's what most people are when they're on treatment and they take their treatment regularly. They cannot transmit HIV sexually to another person. So, there is no, they do not transmit infection. HIV cure is a very complicated thing. Lots of research, no cure yet. Very tricky. A very interesting question about PrEP. so if somebody's on PrEP and is seroconverting, but we take a very, very clear history and we try and avoid that situation. So we also do a test before they go on PrEP. So if somebody's going to go on pre-exposure prophylaxis, we would do a test beforehand. And if they go on Truvada, there is a small risk that they may get a bit of resistance because they'll have only been on part of the treatment, but there is much more risk in not giving them PrEP. And we have such an array of treatment now that actually it's better to go on PrEP, even if there's a small chance they may have HIV that hasn't come up as a positive test yet. Have I always been fascinated by virology? Not really. I think it was more that I saw some very interesting patients, and I also saw some clinicians who were really engaged and really cared. And I just thought, and that's what happens when you go into medical school. You just find a group of people and you think, oh, I'm like them. Well, that's, what my experience is, and my husband's a doctor as well. You think, oh, I'm like them, I like them, and I feel like them, and I think I'm going to go that way. HIV treatment, so it's ongoing. I mean, our patients at the moment, even though we've got effective prevention, we still have a large number of patients who are going to need lifelong treatment. So we continue to need treatment.
I think we have time.
What can we do to reduce stigma? Also, there's loads of things happening. So basically, by talking freely, by normalizing having the HIV test.
Okay.
Oh, I think I might need to leave it there.
But that's good timing because we're at 7:30. So thank you so much, Fionnuala, for giving up your time tonight. It's been really interesting. And please don't worry about slides problems. This happens all the time. So hopefully you found that interesting. And I'm sorry if we didn't get to your questions. I tried to answer as many as we could in the time that we allowed. What I will do is I'll maybe ask Fionnuala to send some links through to me, and in the follow-up email that we'll send you, we can send them out to you so you can kind of have a look at some of the things that Fionnuala's been talking about in the talk today. So I hope you found it interesting. We're not doing a talk for April. We're having a month off for Easter, and because some of us are going away, but we will be back in May for our talk, and we'll have talks in May, June and July. So we have recorded this, and we will edit and caption it, and then I will send out an email with the link to the presentation, and it will also be on our YouTube channel, where you can find the rest of our previous talks as well, if you'd like to go back and have a look at some of the other talks that we've done over the course of this series. So thank you very much. I'm going to start to wrap this up, and thank you for all your lovely messages that have come through the chat. There's some really nice ones, Fionnuala, you might have spotted in there as well. So enjoy the rest of your evening.